Welcome to Mayo Clinic Q&A. I'm Dr. Sanj Kakar. We're recording this podcast on April 17th, 2020. As we continue our coverage on COVID-19, with us is Mayo Clinic COVID-19 expert, Dr. Greg Poland. Dr. Poland, thanks again for joining us.
Yeah, good to be here with you.
So a lot has happened in the last 100 days compared to where we are now. What's our understanding in terms of the last 3 months as we move forward?
Oh, it is truly astounding to me to think, a mere 14 weeks ago, this canvas we call COVID-19 was blank. Nobody knew anything about it. And then this thing emerges in January. At least we get notified about it in January. And when you think about the last 100 days, we know the genetic sequence of this virus. We know how it enters the body and causes disease. We're doing studies on antivirals, convalescent plasma, vaccines. We know how it's transmitted. We know a lot about differential severity of illness and chance of death based on age and comorbidities. We know how this virus affects things hematologically, gastrointestinally, hepatic, renal, neurologic, pulmonary, cardiac. I mean, a wealth of information developed. One of the things that's really interesting from an infectious disease point of view is while we talk about it all the time, we're living through a real life demonstration of the power of hand washing, respiratory etiquette, and mask wearing, and distancing from one another. And it's powerfully effective. We've learned a lot about transmission models. Sanj, when you and I went to medical school, it was sort of as simple as, well, there's aerosolized droplets and there's large respiratory droplets, right? It's that simple. Well, it turns out to be a lot more complex than that. And models showing that in some scenarios, you may have to be as far as 30 feet apart from somebody. And that if there's inadequate exchanges of air in a room, that this virus can hang around for 20 minutes and longer. We've learned about the effectiveness of PPE. We've learned we're better together in a way that has been very powerfully demonstrated, and just how interconnected we are. And then I think, kind of maybe on the somewhat negative but also learning side, is deniability has been taken away from us. This is the third novel coronavirus in 18 years. I don't think there's a healthcare system or clinic or hospital in the world now that doesn't understand the necessity for preparedness. Now, we've been blessed. We're in an institution where we're very well prepared. But that's not the case for a lot of institutions and in a lot of areas of the world. And I think we're going to learn a lot about that.
Yeah, there's some great points there. As you said, everybody, not only just within Mayo Clinic working together, but across the nation and across the world. And you do feel proud when you see Mayo Clinic helping spearheading some of these changes and developments. One thing that you taught me was about the effect of coronavirus on the heart. But recently, we're listening that it can affect the brain. For example, younger people coming in with stroke-like symptoms. Can you talk a little bit about that?
It turns out that in some ways, oddly, in some ways not so odd, that a disease that involves this much inflammation also leads to thrombosis, both arterial and venous. And so you're seeing TIAs and stroke-like symptoms. You're seeing coagulopathies. And in fact, in the centers that are seeing the most number of cases, they're starting to look at anticoagulation in their more severely ill patients. So this is something that one wonders how often this has happened in other highly inflammatory states, that because they are one-off cases, we haven't seen in the concentration that we're seeing with COVID-19. And so I think paradoxically, this surge in COVID-19 cases is going to profoundly and very positively affect critical care in a lot of areas different than COVID-19. I'll give you another example. There's beginning to be pretty compelling evidence that when we have to ventilate patients, putting them at least part of the time in the prone position, that is stomach down position, rather than the standard, on your back position, may actually benefit them in terms of ventilatory support. So this is going to be useful knowledge that we gain for many diseases.
And as you said, we've been talking about the short-term ramifications of COVID-19, assuming patients recover, and even patients who aren't showing symptoms but test positive to this. How do you think it's going to affect their long-term health?
I think there will be physical and even emotional scars, if you will. One of the things that appears to be happening is that in some cases, almost a fibrotic-like pulmonary picture seems to be emerging. There can be neurologic consequences, as we've talked about. There have been at least short to midterm renal and hepatic consequences. Will those turn out to be long-term? There have been encephalopathies described. When we talk about long-term, one of the things that I think remains to be learned is when a pregnant woman, for example, might transmit the infection to her baby. Are there any sequelae from that? So far, none that I'm aware of. Mm-hmm. But will that be true in the mid to long term? That's something that I think has to be watched for at this point.
It's definitely changed our world from now and the future. Looking back in the past, obviously, tuberculosis used to be an issue, and there's a vaccine had been developed. Any thoughts about how that vaccine could help with coronavirus?
Yeah, this is very interesting. The proposal has come up that could BCG vaccine be helpful in an indirect sense. The idea is this: as people have done some ecologic studies, and there are great dangers in those, but the idea being, let's look at a country that gives BCG, look at a country that doesn't give BCG to their children, and we don't in the US. Are there differences in death rates due to COVID-19? And indeed, in some of those ecological analyses, there are differences where people that have gotten BCG seem to do better. Is it likely that a vaccine given in childhood is actually benefiting you when you get infected with COVID-19 as an adult? I highly doubt it. I think it's probably an ecological fallacy, is what it would be called. But those are simple studies to do, and they are proceeding. I don't think they're going to pan out.
Well, thank you for sharing that, because obviously everyone's looking for a ray of sunshine here, and it's important to have some perspective in what we read and what we hear. So I appreciate, Dr. Poland, you giving us that perspective.
And
the other thing that
there is a ray of sunshine in that we now have a second study suggesting, now these are uncontrolled studies, but a second study suggesting the benefit of an antiviral called remdesivir. We need and soon will have much larger studies, but it has motivated these larger studies to continue. So we're hopeful that that will turn out to be something important. One thing to point out is that often these therapies are applied, because they're not yet licensed drugs, in the sickest of the sickest. But as you might imagine, if you wait too long, that is to say, the ideal time to give an antiviral would be early in the course, not once they're critically ill. I think this will motivate us trying the use of these therapies, both plasma and antivirals, earlier in the course of COVID-19.
So it's interesting you mentioned about earlier in the course of the disease. I've been reading that there's some thought process that you're actually most infectious before you actually manifest with the symptoms. So what are your thoughts about that? Because obviously that does change one's thought process about how a carrier can infect others.
Yeah, that's actually a very keen insight. And you're right, about a day to 3 days is what it looks like before you develop symptoms. You can actually be infectious to other people. By the way, that's true with influenza too. The hard part about that, of course, is we generally wouldn't treat somebody until they develop symptoms. And in the case of influenza, just to give one point of reference, we need to treat those patients with antivirals within 48 at maximum 72 hours in order to get the full benefit of that antiviral. Well, that implies testing, right? We have point of care testing for flu. So you can come in to see me in 15 minutes. I can say, yep, you're flu positive or negative. If you're flu positive and you're at risk, I can write a prescription, treat you with an antiviral. That's where we're evolving to with COVID-19, is the ability to do the same thing once we have antivirals and testing.
As you see, as we're evolving, eventually social distancing and the requirements may be lessened as we move forward. How do you see us being different in the future? Do you think we'll always need to be practicing social distancing?
I think that's going to become an inevitability. I think we may very well become a culture that, at least in the wintertime, when there are so many respiratory viruses circulating, that will be more like Asian cultures, where they more readily wear masks when they're outdoors. I think we'll take more seriously in clinics and hospitals and nursing homes the respiratory diseases that circulate every year and which lead to hospitalizations and deaths, influenza being the exemplar. I think we've also learned on the medical side, there's a lot we can do with telehealth, telemedicine. We don't necessarily need to bring everybody in, expose them to some of the potential dangers of that in order to advise them as to what the next course of treatment or the next diagnostic test may be. As we develop vaccines against these respiratory diseases, I hope we'll take vaccination more seriously. When you think about influenza, people over the age of 65 account for 90% of the deaths due to flu. And yet maybe we get 50, 60% of them to take the flu vaccine. So this may energize the whole enterprise of vaccines as a way of preventing disease.
That's a great point. I think we were lulled into false sense of security with modern medicine being so good, how important vaccination is, not just from childbirth, but throughout one's life, as recommended by our healthcare providers. Dr. Poland, anything else you would like to add?
I think a couple of things. One of the things that's really important from a medical point of view, and this data just came out, it doesn't surprise me. I mentioned this in interviews for the last couple of months. Turns out that about 20% of patients that are COVID-19 positive are also positive for another respiratory pathogen. So this is really important because it motivates us in a couple of ways. Our hand washing, mask wearing, and social distancing isn't just for COVID-19. It involves all of this host of other respiratory viruses too. The second thing is that when we're doing diagnostic testing, they may be COVID positive, but that doesn't mean they might not simultaneously be influenza positive. And that's important because we have highly effective antivirals. So I think we're learning a lot more about co-infections and the role of those co-infections in terms of severity of illness and treatment.
Our thanks to Mayo Clinic infectious disease and vaccine expert, Dr. Greg Poland. As always, great information to help our listeners stay up to date with the COVID-19 pandemic. Thanks again, Dr. Poland.
My pleasure. Good to be helpful, and so glad we're able to get this information out.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.